Hi and welcome to another video. Today we're going to be talking about the clinically high yield points about acute renal failure. Now we're going to be looking at the clinical points, the most important points with the underlying pathology, and we'll start with our patient's presentation. So the presentation of the patient is most importantly, actually, they have normal sized kidneys, okay? That is a indicator, okay? So the acute renal failure is something that is recent onset and it starts more suddenly. And the fact that it does so means that unlike more chronic conditions, till now, there's no changes, atrophic changes, for example, to the kidneys. Remember, atrophic changes would indicate then a shrunken kidney. So here we have normal sized kidneys. Okay, biggest symptom of our patient, oliguria. Remember, low oli, so this is a low urine output. Okay, now they present with oliguria, which is as low as less than 400 milliliters per day or 0.5 ml per hour. And this is all because of the kidney not being able to produce enough urine output, okay? And there are rises in the serum urea and creatinine. And remember what azotemia is. And there can be symptoms, there can be signs such as hyperkalemia and metabolic acidosis in the case of acute renal failure. Remember, we're always looking at the normal versus abnormal. To really prime your mind towards diagnosis, we need to always be considering what's normal and what's abnormal, okay? So what can be the causes of acute renal failure? Now, I'm going to try and really simplify it for you because this could take a while, but if you understand these main simple concepts, it will be so easy for you to understand what exactly is acute renal failure and what can cause it. There's three things. The heart pumps blood to the kidneys then excrete in the form of a water. Okay, now when the heart pumps blood to the kidney, this whole area from the heart to the kidney is known as pre-renal. So if there is a problem in the kidney, most typically there is something called urea and creatinine, and urea is being filtered by the kidney and then reabsorbed. Creatinine is being filtered by the kidney and it's basically virtually nothing is reabsorbed. Virtually nothing of creatinine is reabsorbed. Let's just stick to that. However, very, very tiny amounts of creatinine are reabsorbed. But this urea that is reabsorbed, we can then use that blood urea nitrogen as an indicator for kidney damage. So all you need to know is that blood urea nitrogen, or BUN, or that increasing in nitrogen containing compounds within the blood, that's known as azotemia. So if you understand what azotemia is, then I can tell you that anything before the kidney is all to do with the heart and the pumping of blood. Anything within the kidney so that's pre-renal. It's before the kidney, pre-renal. Within the kidney is intrarenal, and anything after the kidney is post-renal. Okay? So if you have failure, you are more likely to then have pre-renal azotemia. Post-renal azotemia. It's called azotemia. You have to get comfortable using these terms because you will be expected to know these when clinicals start, okay? So you need to be comfortable with azotemia, and I will make a video which just explains everything, all the key terms you need to know, okay? So don't worry about that. When it is a kidney problem, when it's the kidney itself that's the problem, remember that line, it's not you, it's me, that people give? That's the kidney. It's not anything else, it's the kidney. And that's then intrarenal failure. So acute renal failure can be caused by pre-renal, intrarenal, and post-renal failure. Okay? Pre-renal, everything to do with cardio, with the heart, anything to do with the heart, or anything to do with the amount of blood that is being pumped to the kidney. So your number one is shock. Hypovolemia. In what cases is there decrease in the amount of fluids that are being pumped to the heart, okay, congestive cardiac failure. Think of sepsis. And you can even think of renal artery stenosis. Okay, renal artery stenosis is very common. It's not that common, but it's a very common pathology in pre-renal failure. And yeah, it's kind of like a direct obstruction, isn't it? Intrarenal glomerulonephritis. I've got another video on this. Consider glomerulonephritis and consider RTA, renal tubular acidosis. Renal tubular acidosis is when the tubules lining the PCT, lining the tubes of the nephron, are then damaged. And if there is damage to the renal tubules, to the cells lining the renal tubules, answer me, can you then reabsorb BUN creatinine? No, it makes it very, very difficult to reabsorb. It's more so excreted into the urine. There's two types of RTA. There's ischemic and toxic. When it comes to toxic, clinically high yield nephrotoxic drugs. There are some drugs that that are very commonly having nephrotoxic side effects, such as aminoglycosides. Name an aminoglycoside: gentamicin. What else? NSAIDs, non-steroidal anti-inflammatory drugs. Cisplatin, for example, which is used a lot in chemotherapy. Then, also, you have vancomycin. What is vancomycin used in? MRSA. You need to remember this. These are the high-yield drugs. You need to know these. Vancomycin is used in methicillin-resistant Staph aureus. Okay, what other drugs? Okay, gentamicin, as we discussed. So, if a patient comes to you saying, "Doctor, I had an infection, I had some kind of infection, I was getting gentamicin for it, now I suddenly have low urine output, I'm having these kidney problems," you need to think. If it's a patient who has previously had chemotherapy, cisplatin. If it's a patient who was taking NSAIDs, for example, for chronic pain, you need to be thinking nephrotoxic side effects. Okay, so what else are the post-renal complications? Post-renal is anything to do with the bladder, okay? It pumps from the heart, goes to the kidney, from the kidney to the excretion pathway, bladder related. Any urinary tract obstruction will give you post-renal implications. Now, these can be stones, calculi, or it can even be something such as benign prostatic hyperplasia. What happens in BPH? There's an enlargement of the prostate in the periurethral zone and the consecutive narrowing of the urethra. Remember the complications of BPH, but just remember BPH affects older men. It commonly presents with symptoms. 68-year-old male now presents with increased urgency and nocturia, so needing to frequently urinate during the night. Okay, so BPH. So you need to keep these differentials in your mind when you have a acute renal failure patient. So again, I will do labs. So labs will be a different video because there's a lot of conceptual work that needs to go in behind that. What is the management? Okay, you're a doctor. The management is going to depend on the cause. Okay, so what is the cause of the acute renal failure? So it really helps, by the way, all three of those, pre-renal, intrarenal, and post-renal, have different lab workups, and those lab workups can help us. So if you know whether it's something to do with the heart, if it's something to do with the bladder, the symptoms, firstly, you can tell from the symptoms. Secondly, the labs are your best friend. You need to use your labs more as a confirmatory, okay? And then, knowing from the labs, which can indicate what was the cause, you can then treat it accordingly, okay? So if it's hyperperfusion related, so this is a pre-renal cause, you're going to give conservative management fluids. Okay, you're going to be giving fluids as a conservative management. In the case of renal artery stenosis, you're going to do stenting, okay? And then in the case of renal, obstruction For example, in the case of, glomerular nephritis, you're then going to treat the glomerular nephritis. In the case of nephrotoxic drugs being used, you're going to stop the usage of that drug, okay? What are the post-renal causes? There was obstruction, right? So then how are you going to treat that? Surgery. You're going to get rid of that stone, okay? There's something called obstructive uropathy, which is caused by kind of like a buildup, right? It's because if something's being obstructed, you're going to have a pathology in the buildup of urine, and in that case, you want to drain the urine, and that's nephrostomy. That procedure is known as nephrostomy. Now, when it comes to knowing what is important, what are the high yields, at the end of the video, I'll tell you what you must know at the basic level, what you want to know at the intermediate level, and what you want to know if you really want to kind of shine and go the extra mile as well. So I'll divide up the info for you. Complications. What are the complications of acute renal failure? Hyperkalemia. This is a very, very important concept, and if you haven't heard yet, elevated levels of potassium in the body can lead to fatal arrhythmias, okay? So elevated levels of potassium are bad because they can lead to fatal arrhythmias. So what will you do next? You need to keep in your mind IV cal glue. IV, intravenous, cal glue, okay? So you will be asked about this, and you will need to talk about cal glue, which is my way of saying calcium gluconate. Of course, if hyperkalemia is an indication for arrhythmias, then you will have ECG changes. What kind of ECG changes? A tall T wave, an absent P wave, or a broad QRS complex. So just remember, a tall T wave, something that's extra tall, and then something that's absent P wave. You must look for hyperkalemia-related ECG changes because these are going to dictate your management as well. So for example, if potassium is more than 7 or there are ECG changes present, then in that case, you will give IV calcium gluconate. That is like your antidote for hyperkalemia. If potassium is less than 7 and there's no ECG changes, in this case, you will give treatment IV insulin and dextrose. Why? Do you know what is special about dextrose? Dextrose stimulates the this all stimulates the intracellular uptake of potassium. Okay. So we always need to do cardio protection. Okay. Whenever there's hyperkalemia, this is C-protect, okay, C-protect, which is cardio protection, and in that case you need to give calcium gluconate. So what if the hyperkalemia isn't responding to the drugs? In that case, that could be an indication for dialysis. So at the end of the video, I'm going to cover all the indications for dialysis because they are very important. And now, I'm going to cover the other complications of acute renal failure. So once again, just to reiterate, hyperkalemia is a major complication of acute renal failure. However, it could be life-threatening in the cases of arrhythmias, and dialysis was given if the potassium is more than 7 and the current hyperkalemia is not responding to treatment. Pulmonary edema is the second complication of hyperkalemia, and it is actually life-threatening, and it's due to the fluid overload. So what are the kidneys doing? The kidneys are excreting and filtering. When the kidneys are filtering and excreting, fluid is lost in the urine. If the kidneys are not able to do their basic fundamental functions, such as filtration and excretion, fluid buildup will occur, fluid overload will occur, and pulmonary edema could occur. So starts accumulation of fluid in the blood vessels. When the kidneys are not taking out the fluid, there's edema, there's ascites, and pulmonary edema, once again, is the life-threatening complication. So we've talked about this, and okay. So what are we going to see? On investigation, we are going to see X-ray has, remember you do an X-ray in the case of pulmonary edema, and it's going to have curly B lines. These curly B lines are going to be hallmarks. Treatment is very important. It's an IV diuretic, and it's going to be furosemide. Furosemide, the IV diuretic, is going to be the treatment. Also 100% high flow oxygen, as well as prop up the patient because of naturally orthopnea is occurring. Okay. So furosemide IV, do not forget, important. If the patient is still not better, by the way, what is, I didn't mention, the classical symptom of pulmonary edema is shortness of breath, dyspnea, and pink frothy sputum, okay? Pink frothy sputum. So if their shortness of breath does not get better, if they're still not better after the diuretics are given, that is then an indication for dialysis. Okay, so we've got a few common indications for dialysis. Okay, number 3, you can have hyperkalemia, pulmonary edema, as well as bleeding. This is due to hyperuremic state. The urea is too high, creatinine is high, and with the hyperkalemia, okay. In the overview of this all, we have to think that we have to remember at the basic level, you need to remember that there will be oliguria in the patient. There will be low urine output. There will also be normal-sized kidneys in acute renal failure, okay? This is level 1 of the knowledge which you should have, okay? Level 1 is knowing what ARF is, what the kidney size looks like in ARF, and also what are the pre-renal, intrarenal, and post-renal causes in ARF. Remember, common nephrotoxic drugs can trigger intrarenal acute renal failure. You need to know that management is conservative by fluids in the initial state, and you need to know that you're going to be treating the cause initially of the acute renal failure. Is it something pre-renal, aka shock related? You need to give fluids. So also the management for nephrostomy is level 2, if you can remember that. Level 2 is also remembering, this is the intermediate level you're expected. Know the complications of acute renal failure. So there is hyperkalemia. Why is there hyperkalemia? What are the consequences of having hyperkalemia on the heart? What is IV cal glue? Pulmonary edema, and the characteristic X-ray findings and the treatment for pulmonary edema, furosemide. That's also very important. Okay, those are more high yield concepts, and they are the ones that are intermediate. You should know if you want to go higher. What are the indications for dialysis? Okay, if you understand these concepts, this will make your life a lot easier when it comes to wards. Okay, and actually I did this as intermediate. However, when it comes to 4th year, this is very important to remember that the treatment for hyperkalemia is IV cal glue, and also remember the ECG changes in the case of hyperkalemia. Indications for dialysis. Severe metabolic acidosis. When you're more acidic, it's less than pH 7.2. So in this case, it's pH less than 7.2, which is severe metabolic acidosis. Another indication for dialysis is when you have pulmonary edema that is not being resolved by the medication. We also mentioned pH less than 7.2. Hyperuricemia is an indication for dialysis. And the hyperuricemia can then have encephalopathy-related consequences, pericarditis, and do not forget hyperkalemia that is not responding to the IV cal glue. Then that is also an indication for dialysis. Okay, so I hope that was helpful, and we covered a lot. We covered a lot of things that are both pathophysiology related, internal med, just understanding the management, the complications, and the treatment for the complications, indications for dialysis. If you enjoyed this video, please leave a comment and subscribe. Thank you so much.